Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites umedicaldoubts.blogspot.in and drraghavamedicaldoubts.in. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatments, and surgery details when necessary. For the medical knowledge to general people and for reference to the medicos. Today I am going to discuss about the prostatitis, symptoms and treatment. Prostatitis is the inflammation of the prostate gland. It may be acute or chronic. In both types, there is a triad of pathological conditions: posterior urethritis, prostatitis, and seminal vesiculitis. Symptoms due to infection of any one of these may predominate. Acute prostatitis etiology. Acute prostatitis is common, may be caused by the hematogenous route, that is through the blood from the distant focus. Infection anywhere in the body, like tonsillitis, caries tooth, diverticulitis, tuberculosis. Sometimes the infection ascends from the urethra or descends from the bladder or kidney. Usually caused by Escherichia coli, Staphylococcus aureus, or Albus streptococcus faecalis, or gonococcus. Clinical features. As with any infection, symptoms include may have shivers, rigors, aches, and all over, especially back. The temperature may be up to 1 or 2 degree Fahrenheit or 39 degrees centigrade. Dysuria, but may not be variable. Perineal heaviness, rectal irritation, and pain on defecation. On rectal examination, one lobe of prostate may be felt and tender. One lobe may be swollen more than the other. Seminal vesicles may be involved. Treatment. To prevent the recurrence and to ensure complete eradication of infection, immediate, prolonged, and rigorous treatment is necessary. Delay in treatment may cause the spread of infection to the epididymis and testes. Advised bed rest, copious fluids, broad spectrum antibiotics like tetracycline may be given until the culture and sensitivity results come. Then the treatment continues according to the results. It should be followed by 1 month course of long-acting sulfonamides as sulfomethoxypyridazine to prevent recurrence. Bed rest for 14 days and avoiding sex for 6 weeks is enough. Prostatic abscess. Besides the usual symptoms, above severe uncontrolled pain in the perineal and rectal region with the occasional tenesmus. On rectal examination, prostate is felt enlarged and hot, tender, and softened in one place. Retention of urine is there. Treatment. The abscess should be drained immediately. If catheter ruptures the abscess into the urethra, but the drainage is insufficient and followed by intractable chronic prostatitis or a residual abscess. The abscess can be drained by per-urethral resection, unroofing the whole cavity. Perineal route is preferable when there is a marked periprostatic spread. Chronic prostatitis. It is a result of incompletely treated acute prostatitis. Smears and culture usually show the causative bacteria. Predominant organisms are E. coli, Staphylococci, Streptococci, and diphtheroids in the same order. Recently, Trichomonas is found to be the cause, if so, present in both partners. Pathology. The lumen of the ducts blocked with debris and pus. This causes soft enlargement of the organ. When due to fibrosis, the organ becomes smaller and harder. Symptoms. Chronic posterior urethritis. Confirmed by confirmed only after irrigating the urethra and massaging the prostate. The resultant specimen shows more than 15 pus cells. Epididymitis. It usually occurs secondary to prostatitis. Pain. It is usually dull in the perineum or rectum, more on sitting on a hard surface. Referred pain may be to the back extending to the leg. Silent prostatitis. Arthritis, myositis, neuritis, iritis, and conjunctivitis are explained after getting pus from the prostate. Recurring attacks of fever lasting about 3 days accompanied by malaise. Sexual dysfunction, premature ejaculation, prostaturia, and impotence are sometimes due to prostatitis. Diagnosis. 3-glass urine test is useful. If the first glass contains prostatic threads, rectal examination. The gland is smaller and hard. Prostatic fluid is confirmative. It is opalescent and viscid. Stained specimens show many pus cells and few bacteria. Unstained films may show epithelial cells and, if present, trichomonas. Urethroscopy shows inflammation of prostatic urethra and pus at the end of the ducts. The tenom is enlarged and edematous. Treatment. Antibiotic given according to the sensitivity test. More than 5 grams TDS of a suitable sulfonamide, example sulfur triad for 6 weeks, is a good recommendation. If organism is trichomonas, administration of metronidazole 200 mg 3 times a day orally after meals to both the partners. Massage of prostate per rectum is an important measure. The prostatic secretion and contents of the seminal vesicles are emptied. Usually 8 strokes are given on each side daily for a week. And then at lengthening intervals, as there is improvement. At later stages of treatment, urethral dilatation serves to open the prostatic ducts and permits better drainage. After apparent cure, prostatic massage is performed 2 times at monthly intervals and the fluid examined for re-infection. That's all about the prostatitis. In the next video, I will discuss about some other diseases. Thank you.